only half a glass. Challenge and processing. I'd like this to be a lively and interactive session with input from the audience if anybody feels compelled to speak. We are streaming live on Twitter, so please could the panel be mindful of that, some of their responses. Please do enjoy the gin. There's 4 varieties. It's rather good, isn't it? I've gone for the rose. Enjoy the gin, but not too much. We're having what we hope used to be called, any of you of my vintage will refer to as sharpeners before the gala dinner, so let's be all really sharp during this. And as the youth in the room, I would like you to tweet with impunity to encourage a bit of what they call FOMO, I believe. So, I want to introduce our illustrious panel, and they really are quite amazing. So, to start with, on my left, we have Dr. Hobart Harris, who I have to say, if nothing else, has about the coolest name of any surgeon I've ever encountered. Hobart is professor and chief of the section of GI surgery in University of California, San Francisco. Like, let's all go there. How amazing. He has numerous other titles, which I can't possibly list, but is interested in abdominal wall, infection. He has a big academic portfolio, a big training portfolio. This guy's the real deal. So we might hope our panelists learn something from him this evening. Next along, we have Miss Trish Duncan, who is a consultant hepatobiliary and general surgeon at University Hospital Wales in Cardiff, and also an ASGBI regional rep.
Thank you.
Now, I'm really sorry, we had to make up space in the panel. We were looking, and I bumped into this elderly gentleman at last week's Association of Choleproctology meeting. I'm delighted to introduce Mr. Richard Guy, we go back a long way, who says on his own Twitter handle that he's a colorectal surgeon who is now pushing the EGS agenda. So we're hoping he'll be pushing it live in front of you tonight. And he works in nearby Arrow Park and told me that nobody would come tonight because apparently there's a big football match on. What does he know? I next have Miss Liz Vaughan, who is the president of our Moynihan Academy, the ASGBI Trainee Association. Liz is a trainee in the Yorkshire and Humber Deanery and is passionate about trauma. So hopefully we'll hear from Liz a lot. And then next, Ross Davenport, academic trauma and vascular surgeon at the Royal London, who'll know tons, one of those trauma junkie types of people. So I'm slightly scared because I've got some trauma slides and I know nothing about trauma. And then at the end we have Mel Paul, who is research fellow in Health Education East Midlands Deanery and surgical trainee in the south of our school. Welcome to our whole panel. Please give them a round of applause. Now tonight with these questions there will be points. And we all know what points mean, don't we? Thank you. Loss of your driving license, actually, is what points mean. So, we're going to move on. So, our first case, and we're going to mix up surgical cases with general knowledge cases because we're all going to come away having learned some stuff. So, we have an ovarian cancer patient who is a 68-year-old lady with stage 3C ovarian cancer on cisplatin. So, I'm going to go to you, Mr. Guy. Would you like to tell us what stage 3C ovarian cancer is?
I hope I do get my own back. Well, it's further on than stage 1 and stage 2.
Brilliant.
Much worse.
Extremely logical. 5 points to Mr. Guy. Fantastic. Does anybody know anything about ovarian cancer? Why would we come on? So, stage 3C ovarian cancer is when your primary is in ovary or fallopian tube and it has spread to have deposits of larger than 2 centimetres throughout the abdomen, sometimes retroperitoneal lymphadenopathy involved with the disease. So bad disease. So this lady's on the oncology ward having cisplatin, and on Sunday afternoon they call you to say she's having a massive PR bleed. This is a real life case. So we might go to Liz. Liz, our trainee, massive PR bleed, you're the reg on call. How are you going to manage that situation?
So in the first instance, I have to make sure I resuscitate the patient, so I go through my ABCDE. If she's having a massive bleed, I'd want to activate the massive transfusion protocol straight away.
Yes.
She is at a high risk for DVTs and PEs, so her risk of VTE might preclude her from having tranexamic acid, but I would still give it in this instance because the risk or the benefits would outweigh the risks.
I just want to interrupt slightly and ask Mr. Davenport, why are you so excited about the major transfusion?
all will become clear.
Oh, okay.
The other thing I think that's incredibly important about this, and particularly in PR bleeding, just because somebody has a different pathology doesn't mean that they couldn't be having a massive bleed from a hemorrhoid. So it's important to look and see if there's any compressible bleed and basically stop it. So You also need to get help on board straight away because it's going to be too much to manage as an individual. So you need to let your theatre staff know, see if we can stabilise her to any degree that she might go down for angioembolism. So you need to let the
Okay,
radiologist
too good, I'm bored. I'm examining your FRCS and I'm bored. I switched off after 2 minutes in. So you get a kind of the test that you have alluded to. So we have here, now, who? Trish. Do you want to, there's a bit of liver in this. Do you want to...
I can see the liver. There it is.
Is that it? Anybody,
Do you know
anything?
CT angio?
It is going to be. This is the pre-contrast phase.
Okay, lovely.
Any smudgy bits standing out at all?
This view is a bit awkward, but not usually.
Trish recently had her hair cut at the expense of the ASGBI to film
Oh,
a Twitter video about being a regional rep. That's kind of true. It's great hair, don't you think? I think it's great hair.
I'm too old to turn.
Where's my lovely Basque colleague?
We do have a crash team prepped, just in case.
There's a bit of gas in the middle.
There is. So this first slide shows us that the left kidney doesn't look great, does it? Let's have a vascular opinion. Come on.
No clue. I haven't got a clue.
No clue. Good. Classic vascular response. It's not vascular.
Anything to...
So there's a big something going on with the left kidney, isn't there? And if I had a pointer, I'd point. But imagine there are some free gas bubbles as well nearby. So then we start a bit now. Mr. Davenport.
Oh, yeah, that's nice.
So there's some contrast in some stuff now.
Yeah.
Blood vessel stuff.
So the
Ooh.
left kidney looks like it's not enhancing. And there is
Thank
some
you.
contrast that's probably in the wrong place.
So we've got a bit of something going on. This left kidney's looking worse and worse, isn't it? And we learnt, you will recall, not 30 seconds ago, that stage 3C had retroperitoneal lymphadenopathy involved with cancer. And the blood's coming out of her bottom, and these are her guts. So we'll get there. So they elected to do an angiography. Now, I don't want to put upon our poor jet-lagged lovely visitor with the coolest name in the world because I feel mean. I think you should have an easy ride because you've travelled so far. Any comments on this image?
Yeah, it looks like there's a aneurysmal dilatation
Perfect.
here on the
Perfect.
left.
The American surgeons, it's just like a different quality, isn't it?
Here we go. He's not drinking gin.
Yeah, he's not on the gin.
And no gin. 10 points to Hobart. There is an aneurysm of the left renal artery. And the blood's coming out of the bottom. So, Mr. Davenport, our vascular expert, what do you think might have happened?
Call urology.
Yeah, fair enough. Okay, real world answers. So they decide this is an aneurysm and with a fistula, and they're going to deploy a stent. So they put a wire in. Which organ? Mel, I've been neglecting you on the end. Which organ are we seeing in this angiogram?
I'm hoping it's the kidney still.
It is the left kidney. That's marvellous. And so they're going to put a covered stent in, exclude this aneurysm, and Bob's your uncle, and thank God for interventional radiology, huh? So they're beginning to deploy this stent. What do we know the name of the stent, Mr. Davenport? You vascular person.
Some sort of self-expanding metal stent.
Exactly. It began with an N, I've forgotten. So, yeah, we have that stent. They deploy it. Bob's your uncle. Looks great, doesn't it? It's all nice. It's opened up wide. Everything's good. And then they always do this post-deployment film. Oh. Why ooh? Yes, ooh, but why?
Still a blush. It's still
Yeah, it's still filling, isn't
Still
it?
leaking.
So I want to say, I asked a surgeon, I'm not going to reveal any names, but he shares my house, what he would do at this point, and he said a left nephrectomy. Duh. Would we do a left nephrectomy? Mr. Guy, I'm sparing you, I'm victimising Mr. London, said, would you?
Would I do left nephrectomy for that?
You wouldn't, would you?
I'm assuming tell us more about the GI bleeding then. This is eroded into
Yeah, D4.
something.
D4.
Okay, and has the bleeding stopped?
Temporarily, yes. All bleeding stops in the end, as we know. Davenport, come on, fill us with your wisdom.
Well, that's not a nice situation to be in, is it? So, in seriously, I mean, this is complicated because,
Tertiary centre referral, no?
yeah, well, you need a couple of consultants in, actually,
Yeah.
to start making some
D4 is
decisions about
not
this.
a fun place
No.
to be.
I mean, you could ask IR whether or not they can do anything else to coil that, potentially, just to stop
Totally.
bleeding.
And that was what they did, line of least resistance. So they just coiled off the kidney and the kidney died, but the patient lived. So thanks to IR. So that's our first case. Well done, people. I'm conscious not to take too long because Miss Duncan and I need to go get our hair done. So that was case one. Marvellous and well done. Now we're going to educate you in all sorts of other areas as well this evening. So this is not a question for Mr. Guy. Not a question for Mr. Guy. Does anybody recognise that attractive young man?
No.
Way, Nelson. Was that the president of our association? Did you go to school, similar age, knew each other? A year ahead of you at school. Excellent. Yeah, we'll leave that. Does anybody else on the panel want to say anything about Admiral Lord Nelson? No.
He was a midshipman on that picture
He was at, how can we tell that's a midshipman?
from the uniform.
Yeah.
Young man.
Excellent. Any more facts about? Just want to say,
Well,
Mr. Guy's a bit like James Bond. He's got a bit of a secret navy. What rank did you attain?
pardon?
What rank did you attain, sir?
Surgeon Commander.
Surgeon Commander in the Royal Navy. I think that deserves a round of applause. Tell us a bit about Horatio then. Which is nearly as cool a name as Hobart.
Where do I start? Horatio, yes. My hero, in fact, died at the Battle of Trafalgar, 1805, 21st of October, which we celebrate every year. But a man of sort of mixed popularity, really. Some local fame here and infamy around the northwest. Of course, his mistress was Emma Hamilton, who was Lady Hamilton, married to Sir William Hamilton, from whom Nelson stole Lady Hamilton. She was brought up across on the Wirral.
Can I just say,
Just-
none of this is prepped at
Just-
all. This
I
is
guess-
just happening.
So this, she was born into poverty in a colliery and moved to London, became a prostitute and a dancer, and moved in high circles thereafter, and ended up actually dying in poverty on the streets of Calais after the death of Nelson. So nobody looked after her, which is what he wanted on his deathbed, of course, in HMS Victory. So she started in poverty, rose to the greatest heights in Naples mainly, and then fell down and died on the streets in poverty again.
Marvellous knowledge.
Fascinating,
Commendable.
woman.
Round of
Yeah.
applause for Mr. Guy. Good historical knowledge.
So masterminds.
Now, flags might feature during this presentation. So again, not Mr. Guy, and I don't know if Mr. Leader's in the room, but when I was running through these at work, he knew it. I was so impressed. Any boys in the room know what these flags are?
Oh, yes.
Ooh, he's just beside
Ooh,
himself. Oh, there's nothing like spoiling a
Yes,
surprise,
good man.
is there? So this is the famous signal. Do you want to tell us about the signal?
I can. It was, the original version was England confides.
But they didn't have the right
They didn't have
letters.
the right flags, so it had to be England expects that every man will do his duty. And it was the rallying call going in to fight the French and the Spanish at the Battle of Trafalgar. So, famous signal, yeah.
And our last picture, why, what?
Is, oh,
It's brandy.
oh, well, his body was put into brandy, so they say.
So they normally chucked everybody overboard if they died at sea, but because he was special, they stuck him in a vat of brandy. Oh, that's lovely. And then brought him home, where he had a state funeral with more than hundreds of thousands of people walking past ceremonially, and he was a great hero. You're absolutely right. Now, that brings us on to, so we're all drinking gin. So this evening we have Liverpool gin, specially selected, I thought was rather nice. 4 varieties, if anybody wants to go and try any more. Mr. Welsh has paid for it all, so you might as well. Navy strength gin, and this is a specialist question for Mr. Guy. What's that about then?
It's strong.
It is strong. So just for the audience, should you go to a bar, refuse it. Navy strength gin is 57% alcohol by volume, and normal gin is 41.2. Why does the Navy need stronger gin? Is it because you're, why is that?
Well,
Don't just make it up, points will be deducted for flannel.
Why do we need it? Well, to fight the French, mostly. Yeah, to give us that kind of determination.
Yeah, so that's not
to
true.
fight the
So
enemy. How about that?
apparently, what it says is because they store things on a ship so near each other, and if that's spilt, it needs to be a higher alcohol proof that the gunpowder will still light. And that's why Navy strength gin is stronger than normal gin. Who knew?
You heard it here.
So enough of that. Boringly, back to another case. So we now have, we've tortured one trainee, we will torture our other. Mel's like, oh, don't. 59-year-old man, this happened in our hospital fairly recently, massive PR bleed, tachycardic, a little bit hypotensive, GCS down a bit, no meds, no nothing, fresh off the street. How will you manage that situation?
Are they in the ward or in ED?
They came to the assessment unit.
Okay. So again, as Liz said with the first patient, it would be A2E assessment. I would gather some friends earlier as well, so the rest of the team, as long as I didn't have another one at the same time, this patient would be priority. And
What if you did have another one at the same time?
well, that has happened
Some
before.
strong delegation.
Yeah.
Excellent.
Call the boss.
That's being empowered by one of those senior female leaders they talked about in the other session.
So as we said, A2E assessment, including getting some big cannulas in early. This chap's obviously shocked, and again, massive transfusion protocol.
Mr. Davenport, do you want to make
Yes.
that noise again? Yeah.
He's got evidence of end organ hypoperfusion if his GCS is 12. If this gentleman, if he stabilises with that, and I get a chance to do a proper good examination, then that will happen as well.
Okay, it doesn't. It's all going to hell.
Great. So I've put in blood, and if his GCS is 12 as well, then if I need to take him to theatre urgently, then consent will be an issue. But in the first instance, I would probably examine him if there's any evidence of active bleeding, then
We can
again,
hear- we
try and
can
get
hear
him to
chuntering
CT
from here.
angio.
We're having shouting. What are we saying, Giles? Somebody says something. It's the right thing.
So,
Angio,
CT
so-
angio.
Mr. Guy, I think you've written some guidelines about this very topic.
I have. I'm slightly worried about massive transfusion going in.
Take it up with Mr.
And
Davenport.
I'll take it back later over some gin. Well,
No, it's all
according
right.
to
That
our-
was fine. You've written some guidelines. Read his guidelines. They're great. So he amazingly had a gastroscopy, which was normal. He then went to CT angio. Now, you've all proven that you're absolutely fantastic at interpreting CT images. So I think, Miss Duncan, again, there's no liver on this one. What do you see? There's several of these before and after bits of stuff.
I can't see anything.
Fair enough.
I
Can't
can
see
see
anything.
the spine, I can see a bit of the aorta. There's not much contrast in the aorta.
It's great hair, though. Look at the hair. It's fantastic hair.
I'm going to play to the audience. What else can I see? There's a bit of gut. Oh,
So maybe with the eye of I know what happened, slight thickening on the right side of his ileocecal valve, but maybe not. It's only one slice. Who knows? So this is another non-contrast section.
there's a bit of
There
contrast
is,
over there.
with the eye of faith, pre-contrast. I'm looking at the vascular eyes of Davenport here again. There's a tiny bit of contrast at the ileocecal area before he's got his contrast at the CT. Then we give the contrast at the CT. We can see contrast in the aorta, and we can still see that little old bit. We know it's old because it was there before. Oh, what then? Vascular surgeon, come on, it's vascular stuff.
Get the IR consultant on this.
Wait, somebody else that's still at home, not coming. Absolutely. So there is a blush of contrast in the ileocecal region. Now, we thought we'd look at slices the other way around. So this is non-contrast. Nothing really except that slightly thickened ileocecal-ish bit. This is contrast. How can you tell? My radiology consultant told me this last week. I thought it was so clever. How can you tell this is the contrast phase? Stunned silence. If you're going to have a heart bypass, what might they use? Other ones, you can see the internal mammaries and the inferior epigastrics. So that tells you it's the contrast phase, and that's why we see the blush. So our radiology consultant, who's really, really good, told us it's definitely the ileocecal region. Take him to the, they thought it was terminal ileum rather than ileocecal himself. So my two colleagues, based on the advice of the, and helped by an older grey male mentor figure who might be in the audience, I think, fresh back from his left nephrectomy, decided he would help. And so They did an on-table enteroscopy with lots and lots of washout and saw nothing.
No.
So what are you going to do then, Krish? What are we going to do then? We've got 2 or 3 enterotomies.
Oh dear.
He's been
Well, obviously,
unstable.
I wouldn't be there in the first place.
So, yeah, in fact,
That
there's
would
many
be-
places we wouldn't be, let's be
that's
honest.
the
Regret's not a
worry.
thing we can do.
And this patient's already had a scope at the top end.
Yep,
haven't they?
that's
Okay.
normal.
Can
And
we,
the IR says it's over there somewhere.
can we scope it?
Just under.
This is very
This
much
is-
out of my comfort zone.
Okay, fair enough, fair enough.
Yeah.
Hobart.
Hmm?
Sorry, itching, itching, no?
So I always try to never find myself in this location.
Yeah, yeah.
Yeah. Agreed.
This is a much better operation to write about than to perform. But I guess if you were convinced that that was the area from the angio, which actually I wasn't, I'm not exactly sure what I would do at this point. If I've scoped from ileocecal valve and you've gone from below as well, and you haven't found the source.
No. So,
Would anyone do a right hemi? Is that what you're asking?
Was there blood in the lumen?
there was lots of blood in the colon, such that the senior surgeon had to wash it out by hand and came home
Yeah.
smelling awful.
So if there's no blood in the small bowel, but there is blood in the colon, then you can kind of locate it to, distal ileum or
So what would you
or
do?
right colon. Well, I mean, this is the sort of situation that we used to be in donkeys years ago. We should never be in this position. But if you've got an angio that's convincing and you find no bleeding, you can exteriorize that. Or you could bring 2 ends out and see which end bleeds. So there is that. You can do an on-table angio. And other than that, you're ending up doing blind resections, which you should never do.
Yeah, fair enough. So what they did at this point, close the
I'm assuming
enterotomies.
someone's looked up the bum.
Yeah, they've looked up as much as they could, but again,
Yeah.
thick blood, unprepped. So the learning point from the other person in the room was he'd always want to prep anybody, even quickly, before you did, because it just sticks so much. Anyway,
White.
White has great hair. So anybody recognise this flag?
An African country?
Not wrong continent.
South America, somewhere.
Miss
It's
Duncan.
Peru?
It's a good
Peru,
guess.
yes. This
So
is
we have the
Peruvian
flag of Peru. Any more clues? Where is that?
Is the Andes.
And then finally, why is this relevant?
Oh,
Yeah.
Milo,
They devour them by the.
they're a little snack.
Yeah.
She looks nice, but she eats guinea pigs.
I
Come on.
don't say that, Joe, because my son would never forgive me.
Do you know the name in Spanish for the dish?
Cuy.
And why is it called that?
Why is it called that? Oh,
So it says online that
is it the little noise they make?
it's the noise they make. And then in our house, it was said that that was the noise they make when they saw they were on the menu. It's not actually the phrase he used, but I don't want to say it out loud because we're
It's
streaming.
really, they're really quite adorable. It's really quite sad because if you go up to Cusco or any of the sort of Andean villages, and you'll see these little garden gates next to what look like ordinary houses, and these little flocks of cute little furry guinea pigs. But if you walk around the corner, the front of the house is the little local restaurant, and they're on the menu. And the way that nobody needs to know this, but the way they're cooked is that they are essentially flash fried. So it doesn't look like non-specific meat. It's literally like this.
Could everybody tweet that still, please?
Really
I think
quite,
that
tastes
goes.
like chicken. really quite distressing.
And
but
you
yes,
have it from our own mouth, it
but
tastes
other
like
than, so I'm
chicken.
half Scot, half Peruvian, and I'll just say if you do go to Peru, rather than the cuy, which is perhaps the local delicacy, have some ceviche instead. It's really much better. Okay.
Marvellous. There we go. So moving on. Less interesting. We have some more surgical stuff. So we now have a 70-year-old male. So we've done our 2 trainees. We've done Mr. Davenport. It's got to be your moment. It's not vascular at all. It's not even about bleeding. It was kind of trauma. 70-year-old male who presents with abdominal pain, breathlessness, tachycardic, normotensive, tachypneic, Everything else okay, the blah, blah, blah is all normal. What are you gonna do?
Go and see them quickly, get an ECG, take a bit more history.
You listen to his chest?
Yeah. What do I hear?
So you don't hear very much on one side.
Not much once.
But luckily, they've done this already. Just anxious that Mr. Guy's going to collapse if he twists around with that vertebral artery lack going.
Right, seeing as I totally
seen
failed on
mine?
the CD, can I say that looks like a tension pneumothorax?
It looks like a tension pneumothorax, and that is what they thought in ED, and they were wrong too. So given
Bleeding, yeah.
given that you think it's a tension pneumothorax, what would you do?
Put a little decompressor.
You'd stick a little decompressor somehow. Mr. Davenport, trauma surgeon, you want to talk us briefly through how we put chest drain in?
Well, it's a controversial subject now.
Oh.
Whether or not you go big or small, or cell dinger or open. But you could be old-fashioned and just stick a big drain in.
Stick a big drain in. So they stuck a big drain in.
How old, what's the ID of this patient?
Oh, 76.
And gender?
Male.
Oh dear.
Chest X-ray?
Sorry, probably is a male. This is why we have these experts from the States. I have incorrectly assigned the gender of my chest x-ray. Yeah, all right.
Looking good.
To be fair, my radiologist sold it as a male to me. So, they put the chest drain in. Did it help?
No.
No. What did it do? It did leak colonic content. That's absolutely right. So we now see the black air space is no longer full of black air and it might have a bit of colon in it. So they did a CT scan. The chest drain doesn't come out brilliantly. It's just at the top, that opacity. So it was a sigmoid volvulus with a diaphragmatic hernia, and it was all up in the left chest. So it just looked like gas, looked like a pneumothorax. So your CT2 saw that destined for greatness. Gita's, yeah, well, she's an IST CT. She's an ST2, actually. I just remember. So that's brilliant, brilliant. So what are we going to do now? Trauma surgeon. We have a traumatic colonic injury.
We've got an effective colopexy there.
We have a...
That's colopexy.
Indeed, it's a very effective colopexy while it lasts. What are we going to do? Chest, abdomen, who?
Abdomen, pull it all back. I mean, I haven't done one of these for a while, but would you take it out? I don't know.
Colonic trauma.
Well, presumably it's overlooked historic trauma and an overlooked diaphragmatic injury from
But right now
years
you've
ago.
got very looked at colonic trauma.
Yeah.
How's the patient?
Patient's okay, less breathless.
The lung is okay. Is it
Coming
lung
back?
expanded? I mean, the patient's okay. You've got a bit of time to...
You can send
Have
them
a
home
think
with the
about
chest
it.
drain in their colon.
With the controlled fistula.
Charles probably would. It's all about ambulatory work in Oxford.
Okay, so if you went to Oxford, you'd go home with the chest drain in your colon. That's genius. Apparently you're advertising 2 jobs, is that right? Maybe more. They reduced it, repaired the colonic injury, did a proximal diversion that didn't really need doing for long. And then how are you going to repair this chronic, enormous diaphragmatic defect? But there's poo around. Any thoughts?
Well, it's probably in the realms of a thoracic surgeon at this point.
Is it?
Potentially. Well, the big holes need a big mesh, don't they?
Kind of mesh. So Mel, I'm neglecting our training. I'm trying to be nice. What kind of mesh are we going to put if we've got poo and colon and a big defect to the diaphragm? I don't know if does anybody know the answer to that?
Biologic, I don't know.
I'd stick something, but I don't even know the name of something expensive. How about any views?
Well, the last one of these I did, I'd probably put in something synthetic like Vicryl and just try and temporize and come back later for a definitive repair.
I'm going to do whatever he says. That voice is
Yeah, that's
fantastic. Completely, yep.
All right.
Do you sing? Oh, can we do singing? So that's brilliant. Moving on. Hobart.
This is my home.
Do you live in there? How did you get out? Anybody in the audience? Alcatraz. This one.
Good Gabriel.
Golden Gate Bridge. Nasty. Well, it's not red, actually. What is the colour? Mr. Lund looked this in. International Orange is the name of that colour. Who knew? Who knew? And then we have this. Now, why do we have this? I'm looking at our Spanish speaker, and she's looking kind of smug. No? Why would you have a pelican with Alcatraz and Golden Gate Bridge? Because Alcatraz is Spanish for pelican. Oh, see, you're learning stuff. This is great knowledge. Right. Conscious that we need to, so a 35, a lot of hair work to be done. 35-year-old man found, this one probably, I think we're going back to our trauma crazy Liz. 35-year-old man found on a roundabout next to his motorcycle, small hours of the morning, helmet on, no visor, unconscious at the scene, tubed, transferred to ED. And it's like, it's your fire, doesn't it? This is trauma. Doesn't like my fire, especially not at 1:30 a.m.
You need to do your primary assessment to begin with and see what injuries he has. Is it actual trauma that's caused him to come off the motorbike? Is it something else? Could it be some kind of cranial injury or something that might have done it? And then, so is he stable? Is he unstable?
So they tube him at the site. Chest bit's all okay, little bit tacky, relatively okay. And we're supposed to ignore this bit about the pupils because they kind of ignore it in the case history they gave me. So pretend his pupils are normal. But they're really excited about the abrasions on his abdomen and pelvis. And then he's not anemic, bit acidotic. What would you do in real life?
Trauma series,
CT. Everybody's airway breathing CT scan. Yeah, so we'll have a CT. So what do we see on there's liver on this one, Trish. There's loads of liver on this one.
The liver. I'm happy now.
Mel, what do we see?
Yeah, that's all right.
Smashed spleen. It's
Oh,
quite
gee.
smashed. Now, Mr. Davenport, you trauma gurus, you're going to sit it out because you're that tough, or what are you going to do?
I'm not sitting that one out, no.
No, even if the patient's normotensive, non-tachycardic, steady
what
as
I
a
would,
rock.
What I would do is actually talk to my IR colleagues. Because the higher the grade of the injury, obviously, the greater the chance of badness is going to start happening for them. And we know that interventional radiology is going to reduce that badness by effectively reducing the grade of the injury. So I think I'd want to see some more pictures.
Yeah.
Just to characterise exactly what's going
Can't
on.
remember if
there.
we've got, I think one more is all you're allowed.
Have we scanned his head yet?
Yeah, it was fine. Well done. They took the helmet off.
I mean, in reality, it's, what sort of resources have you got? Can you observe them very closely? Are you going to be able to get some serial assessments? Look at
So
them?
how closely? So people say that a lot, don't they? And in reality, everybody clears off and does
Yeah.
something. Yeah, exactly.
Well,
So
in
you're
this
going to sit
case-
like Hobart, face to face with this patient all night long. What are you going to do?
Well, it needs to go to a high dependency unit. If you
Yeah.
haven't got space and you haven't got nurses to do, very close observations, then you're going to have to do something more aggressive.
So through lack of resources, you're going to do an operation.
Yeah,
Okay.
because if you miss him on the ward,
Yeah,
he'll
it'd be
bleed to
worse.
death and die.
Fair enough, fair enough. So the asked IR tried a bit, didn't go very well. Things went badly in the IR suite and he rushed off to theatre. And there's a clip on like jelly, really, isn't there? So that's his spleen and everything was better. Now, given that potential magnitude of injury and whatever velocity must have caused that, what's the likelihood of other injuries within the abdomen?
High.
Yeah. So they also found his stomach was all ripped apart and there was gastric, even though the CT was normal. So there was some kind of trauma lesson about, I think anybody who's even no trauma interest would notice a huge hole in the stomach with gastric contents, but have a proper look around even though your CT was normal, was their lesson. Trauma people, Ms. Vaughan, how are we going to sew up that? What are we going to do? Staple, sew, do what to the stomach?
Depends on how stable the patient is. If they're unstable, then certainly you do anything to kind of temporize it. So staple would be, yeah, exactly. It's in the greater curve of the stomach. You could resect it if you wanted, if it's on the greater curve, because you already have taken the splenic artery, so you just go through
Yeah.
gastrocolics and whatever. So you take those down and just resect.
So something quick, get rid of the hole. Mr. Davenport?
Yeah.
Yep, agreeing. All good. Nobody doing anything else? No? Yeah, fair enough. That's what they did. He was fine. I went home. Now, we're getting near to dinner. I am starving because I avoided the curry at lunchtime. I thought I'd be asleep by the time this session happened. So, some patisserie questions, because all surgeons are good at patisserie. Does anybody know... Oh, what this is? I'd just like to say this was my wedding cake. I had one. Does anybody know what it's called?
Croquembouche.
Croque-en-bouche.
A croque-en-bouche. Does anybody know what croque-en-bouche literally means?
Something in the mouth.
Crack in the mouth.
Crunch in the mouth. Very good, audience. Crunch in the mouth. And this?
Breast.
This is a Paris breast. Would you like to describe what's in a Paris breast?
So it's an almond-based patisserie with, it's almost like a choux-type pastry, split in half, with, I think it's crème anglaise, which is normally flavoured, almonds on top, and they sometimes put spun sugar on it as well, but icing sugar.
You
Very
going on Bake Off?
nice.
So my new career after
Invented,
this disastrous panel.
invented to advertise the first Paris breast cycling race, historically. But yeah, really, really nice. So that's our patisserie round. So we're getting towards the end now because everybody's gin's run out and you're all going to become fighty. So I've stolen tips, tricks and traps from the Glasgow Emergency Surgery and Trauma Symposium, who have this nice thing at the end. So starting from our end, do we have a always do and never do? We might start with Hobart. Any particular tip for any abdominal surgery at all in your lifetime of experience to our audience here?
So the never do is obvious. Never devise or perform an operation you've never seen done before.
Fair enough. That's good. That's good advice.
Even if it seems like a good idea at the time.
No matter how clever it may seem. And the always do for me as a GI surgeon is always measure the length of the
Okay, that's
bowel and kind of know quantitatively where you are, what you're taking out, and put that in your op report because the person who operates after you will
Extremely
benefit.
good advice. I think we love that in the room. That's excellent. Ms. Duncan.
Sure, never rush, I feel. Even if you're in a scenario where there's uncontrolled breathing or awful bleeding, occasionally I do get called into some of my colleagues sometimes, and if you've ever had a bleed from the SMV, if you're doing a colorectal resection laparoscopically or a PPPD, it is grim. Pack, get everything ready, call a friend, don't panic, and then move forward. That would be my advice in
Never
general.
rush.
Get control of the situation by packing, call a friend, get your anaesthetist on board, make sure everything's ready, whatever you need, hemostats, clotting agents, and then come back and deal with the problem.
Sound advice.
Because when you panic and you rush, I think that's when bad things happen.
Yeah, I'd agree. Mr. Guy.
Is this trauma or anything?
Anything, and you can tell us about tax returns. Anything.
Pension scheme.
I think as a GI surgeon, know where the duodenum is and
Yeah,
clear
yeah,
the
yeah.
duodenum for right colon pathology and Crohn's disease. Get on the duodenum early. Make sure you've got resectable disease and create that submesenteric plane and the different angles of getting down onto the duodenum. Crucial organ for
I'd agree with
colorectal
that.
surgery.
I'd agree with that. Ms. Vaughan.
I've kind of got two always do's and not really.
Okay, that's okay.
So my always do would be if you're doing a manual evacuation and you don't want your hands to stink, so put a pair of gloves on and then get somebody to scoosh some alcohol gel on your hand before you put a second pair of gloves on, and it just forms this perfect barrier and your hands never smell.
Oh,
like
that is
shit.
great advice. Yeah.
And then the other always do is to do with left colonic surgery. So always document whether or not you've taken down the splenic flexure, because it's so helpful when it comes to restoration of GI continuity. So that would be great.
Excellent, very sage advice. Mr. Davenport, choose vascular, choose life? No?
No. I would say never be afraid to ask for help from anyone with any case that you've got, because, with a bleeding trauma patient, you need somebody to help you very early on, and you'll never regret it. I would always open the Leicester sac in a trauma patient, and that includes looking at everything. You won't regret that either.
Excellent, good advice. And Ms. Paul?
I think, especially for trainees, if you're calling your boss in the middle of the night, it should be kind of for one of three things: to say, I need you, you need to come in. I'm about to do this, is this okay? Or I don't know what to do, but this is the specific scenario and I just need an answer to this question. So I think especially when on the other line it might be a bit foggy and sleep
Are you
adult.
suggesting the elderly
No,
don't
no,
wake
no, not
with
at
a
all.
clear head?
But I mean, just being specific is quite helpful because I know some people do feel quite nervous about having to make that phone call. So I think just
Why
knowing,
might that be?
so just knowing specifically what you're asking and why
I
can
think
make
that's-
the
yeah.
conversation brief, but also useful for both
I
parties.
totally agree with that. Last question, last general knowledge. So we have windscreen wipers, fire escapes, like from West Side Story, and a Kevlar jacket. How are these things related? Any thoughts? Kind of random.
That was something to do with the Kevlar.
They can all get you out of trouble.
Oh, I like. Oh God, I hope that you are cooking on gas. So that could be the answer, couldn't it? They could all get you out of trouble. It's a different answer. Anybody on the panel?
All invented by the same person? I don't know.
Gives a clue.
Okay, they were all invented by women. So, 1917, Mary Anderson invented windscreen wipers. 1965, Stephanie Kwolek invented Kevlar. And 1887, Anna Connolly invented the external building fire escape. So that draws our session and our gin to a close. The hot ticket in town tonight is at the Museum of Liverpool. And for those who forgot their black tie, they will be shamed. We'd like to thank our sponsors, Ethicon, who've been at ASGBI 2022. They're our educational partners. They support us throughout the entire year with webinars and discussions and help for trainees. And the next cool ticket in town will be Harrogate next year, so see you all there. Thank you very much to our panel for being great sports.